We're going to continue with another hot topic, which is the poor die earlier than the rich. And I'd like to call upon Nicolas Bavarez, Martin Hirsch, Silvia Stringini, and the debate will be moderated by my colleague and friend, Brice Gaillet. Good morning, everybody, and welcome to the debate. I think that the reason that I was asked to moderate this debate is because Guy Valencien is really malicious with me, because it so happens that I have a conflict of interest to declare. So therefore, we are authorized to hold the debate, but we do have a conflict of interest. On the debate, on the hot topic of the poor die earlier than the rich, we have Nicolas Bavarez, which I no longer need to present. He's an attorney and an economist and a writer, and he published books in 2012 and 2014. Martin Hirsch, who did Normal Sup and ENA. He has been in charge of humanitarian action at the Ministry of Health, and he was director of Emmaüs for some times. Everybody was young at some point, but we're trying to avoid everybody being poor. He's currently head of the Paris Hospital System, APHP. And his last book is that it's becoming expensive to be poor. We have Silvia Stringini, who's doctor of epidemiology and public health, and she has 2 master's degrees, and she's an assistant at the Social Medicine Institute in Lausanne. You're our university person on this subject. I think it's your preferred subject. I don't know if it's the poor or the inequalities you're interested in, but do poor people die earlier than the rich? And is it poverty as such that kills them, or something else? Well, thank you for inviting me. First of all, I'll start off by telling what I think about the relationship between poverty and health. We've talked a lot about inequality, unfairness, and the gap between the poor and the rich. And I think it's very interesting for the purposes of discussion, but that's not the reality of things. There's a gradient for health, as everybody knows. And it's not only that the poor die earlier and the rich die later. There's a sort of dose-response effect between the rich and the poor and health. That is to say that the richest part of the population has a little bit more health than the poor. There's no threshold effect either, and it's very difficult to divide the population into 2 and say these are going to die young and the others are going to die old. We observe the social and economic gradient for all the social and economic data. I'll just list some. That's revenue to start with, the level of education, social and professional category, to name but a few. Another important one is the parents' profession. As you can imagine, this socio-economic gradient obviously is an important factor, even if we all agree that extreme poverty can lead to risks for your health. It's very difficult to explain that how amongst the people who are not poor, there are still differences, and the fact that you're just a little bit more rich gives you a little more health. And although it's easier to explain something like people who have a master's degree in less good health than those who have a PhD, and a master's in better health than those who have a BA. And those who have a BA are in better health than those who have just graduated. So there's something other than poverty that explains the inequality in your health. Perhaps on political level, we should take a look at the underprivileged layer of the population. But as far as research is concerned, the fact that we have this social and economic gradient is very important to understand the underlying mechanisms of inequality. And apart from the social and economic parameters, and there are a lot of them, and they show a relationship between these parameters and health, there are also mechanisms that explain the gap. There are mechanisms that change when you set up various different systems to modify these parameters. Well, we're talking about mortality, and we've seen that mortality is nothing, and this is nothing new. You gain 2 years every 10 years, and every day you stay alive, you're gaining 6 days. But the difference that there was 50 years ago has not changed. The difference between the rich and the poor, who do die earlier. So why doesn't this change? Is there any explanation for that? Well, I was just talking about the mechanisms that exist, and they don't change. I don't think we're yet in a position to say why they don't change. But certain categories have certain outcomes. And this probably depends on policies that we haven't taken into account. Distributive factors, policies of health, which campaigns to eat 5 fruit and vegetables a day, for example, and trying to get people to stop smoking. All these are things that give people the capacity to act and do something for their health. In relation to the actual mechanism, to give you an overview, we think that 50% of the mortality is environmental and can be explained by people's behavior. Well, we've got 2 specialists here that probably don't have the same point of view as you here. The social aspect is important, but what is your opinion? Which is the most determinant factor in your mind? Well, I think we've got to start off from the phenomenon of globalization, because what you see is that over the last 20 years, there's a sort of mechanism that reduces the gap between the poor and rich countries. Since the 90s, the gap has been reduced by 1/3. But there are inequalities that increase inside the countries, especially in terms of health. The other thing is that health is an asset. And in West Africa today, there's a systemic shock in 2 countries in terms of health. And we're in a poor country, so it's going to be more than just a health issue. It's going to affect society in general. On the basis of that, there are 2 things you can say. First and foremost, France is a very special case because it's a country where the inequalities, it's the only developed country in which the inequalities of income have not increased over the last 20 years, including the tax measures that have been applied over the last 2 years. And you know that our performance is quite acceptable. But the weak points in our health system are the inequalities. And that's interesting. To answer your question, there are 4 types of inequality, males and females. There are 6 to 7 years of difference in life expectancy. There are discrepancies between the South and the North. There are 5 years difference between the North and the South. Social inequalities at 35, whether you're an executive level employee or a worker, the difference is going to be 10 years, which is quite a lot. And lastly, you've got the generation phenomenon, because we know today that poverty is not a problem of the elderly. We have about 18% of youngsters who are in a poor. And as far as warning signs are concerned, we have mental disease and suicides, and you've got the heat wave problem that occurred a few years ago. So there is a problem of revenue, but there's, above all, a problem of inequality. Now, what are the causes of this? Health is a very, very complex thing. The concept that you used is a very real one. That's to say that there are social inequalities in the area of health. That's to say that you've got specific feature of inequality here. This comes from two things. First of all, the concentration of risks, the accumulation of disabilities, poverty, unemployment, no accommodation or housing, and so on. Issues related to professional risks. A worker has 37 times more risk than an executive employee of developing a worksite disease. And then there's drinking and smoking and so on. This gives you the dimension of the risk. Then you've got the problem of access to care. The financial aspects to start with, because we know that for dental care, for example, or above all for glasses, the amounts you have to pay yourself can be very large. 15% of the people say that they didn't care for their disease because for financial reasons. And then you've got the Ile-de-France region, where you have 3.6 doctors for 1,000 inhabitants and less than 2 in Picardy. And you've got the cultural issues we've also mentioned. The last point I'd like to mention, so you can see that the remedies for this, the inequalities in health, are a standalone complex and also a complex issue that require complex measures. And there are a whole series of evolutions that make us think that this is going to get worse, because the standard of living is decreasing by 1% a year here, and the income for our health system is progressing by 0 because we have social issues to solve. Sociology may be part of the answer, but there's also the segmentation to consider. And the last thing is that you've also got the moral dimension, because it's in the underprivileged layers of the population that the theory says that suspicion is the greatest. And there's a sort of refusal to talk to the authorities, as in vaccination. You need to have a very strong policy on inequalities to deal with the problem. Well, I'm sure that we can be energetic and show a lot of willpower, but the whole thing is we've got to know why. Now we have the CMU, the coverage for those who have no other coverage. Why it doesn't work better? We'll come back to the rest later. Yes, you saw the transition between the first round table and now. Stop prescribing statins, prescribe masters. But it was only half a joke, really, because fighting against people who leave school too early is another thing we're not good at in France. And this would be a policy, should be based on a policy that does both things at the same time. That's to say, we've got to get the French population out of poverty, and it all depends on the way that we manage these people and bring them back into the system. I agree on the idea of the gradient. This is something that we see all over the world. To live longer, you've got to become rich. And what we've seen over the last 20 years, a spectacular increase in life expectancy in China. Less spectacular in Africa, of course, but there are a whole series of emerging countries who are now faced with an aging population and a young population at the same time, as a stage of maturity of their social protection system that is quite interesting to look at. So this is the proof all over the world that this phenomenon does exist. And now I think we need to go back to what we said yesterday on the access to water and a whole series of things like this that are very, very basic. So for the gradient, don't forget the extremes. That's to say people who live in the streets. We're closer to, they have a life expectancy that are closer to the expectancy in Sierra Leone. 45 years is the average. They have a lot of disabilities because you don't get to sleep in the street by chance. And there are behavioral reasons as well. In France, we're very bad at prevention. We're very bad at dealing with behavior. and we're fairly good afterwards when we take care of people when they do get access to the healthcare system. But to avoid having cancer, you're better off in England or Scandinavia. And once you've got the cancer, then it's better to come to France to have it looked after here than elsewhere, and things like that.
That was just a little bit of a joke about the public and private sector. Now, France is really in a terrible situation with these threshold effects. These threshold effects, what I mean about this is that policies don't work. Policies that are only targeting poverty don't work, and they're not popular because there's at least one advantage is that poor people are in a minority in our society, and thank God, and we hope that this will continue to be so. But these policies targeting poor people often lead to losing the elections. So we need policies that are progressive, that can take into account all categories of the population. So we need to break down these thresholds, which are monstrous. I hope I tried to do this, helping people to go back to a job. The fact that in the past, when people found a job, they actually lost income. And we tried to fight against this 6 or 7 years ago when I was in the government. And then I remember when I was a member of the government, I received letters from people who said to me, I'm just €1 above the threshold for universal health care, so I have to pay €40 per month. So it costs me €480 per year. So should I send a check to the tax people so that they would actually take away that €1 extra a month so that then I could go back below the threshold and be entitled to free healthcare? And this is the kind of problem that we see that's recurrent in our system, where a portion of the population that could have access to universal health care, and thanks to the public system, there's no barrier in the major public hospitals. It was a little bit more complicated for some of the actors, but we've improved that now, access to universal health care. And then if you're just €1 above that, you don't have access anymore. So we have this CMU, universal health care. You get, for example, a free pair of glasses. But if you're just above the threshold and you're 60 years old, if you arrive at the age of 60 and you are farsighted and you need progressive bifocals, you don't have access to the CMU, so you have to pay your glasses €350. If your revenue is only €700 a month, that's very tough. I always take that example because bifocals are quite expensive. How much do they cost? Each lens actually costs, of the very best quality, €15, and the frames out of China, €10, and out of the Jura in France, €20. So let's say €70. You don't need €350. I'm saying this because the excessive cost of glasses has been organized in France. So, okay, I gave you the optician's margin on top of that. So he does have to make a living. Okay. So I think we can improve this. You see that there's been an excessive cost that's been organized. The inequalities in nutrition, obesity, and the obesity gradient, we have 4 times more of a risk of being obese in the underprivileged social classes rather than in the privileged social classes. And the pediatrician's recommendations on nutrition and water. If you look at the cost of formula, powdered formula for babies, €70 a month it costs. So if you're a mother who's working part-time and you're paid minimum wage, it means 15% of your available income once you've paid your rent must be devoted to your formula. So you continue, look at all these recommendations for fresh fruit, vegetables, etc. It's impossible. I don't think we should solve these problems with subsidies. I think, on the contrary, we can work with all of the economic stakeholders to ensure that there's a business model that would be slightly different and that would allow us to meet these needs. Sylvia according to academic studies, all of these factors, unfortunately, we understand that they're cumulative. You were talking about triple sentences for the underprivileged social categories. Is there one factor that is more important for health overall? We were talking about mortality, but what is pinpointed in the studies? Well, health behavior, in other words, nutrition, physical activity, and tobacco and alcohol consumption. These four factors explain for a large part of this socioeconomic difference. Well, men don't live as long as women, but you can explain this because men smoke more than women and they consume more alcohol than women. We know this as well. And they have often greater professional hazards than women. So a large part of the mechanisms explaining the social inequalities with respect to health are linked to gender inequalities. Also, we also know that health inequalities among women are smaller than what we see among men in terms of social class. You were giving the example this year of differences in life expectancy between executives and workers. If this figure, it's 7 years for men, whereas it's only 2 years for women. So that means that an executive man will live less longer than a worker who's a woman. So yes, there are these health behavioral factors. And there are a certain number of factors that we haven't completely explained, factors such as stress in the workplace, psychosocial factors. Recent studies have revealed the impact of sleep and workload, and as we said, living conditions. And then there's a whole area that's very difficult to modify, things like fatality and predispositions and the personal likelihoods to risk factors or disease. Now, a very well-known biologist who worked on longevity said that according to the studies, 25% is genetic and 75% is the rest. So we should be able to work on the other 75%. What could we envisage to change things? Well, even today, theoretically, we should be able to work on even the genetic proportion. Well, there are four main factors: age, sex, heredity in one block, then lifestyle in the second, then working conditions in the third, and then the general environment in the fourth. And it's not the same thing if you're living in France or in Sierra Leone. What's important is always to look abroad. There are certain countries who have succeeded in reducing these inequalities. Great Britain and the Netherlands, with two systems that are quite different, actually. And this is the logical conclusion of what we've just said. It's like for the welfare state. Well, the welfare state just pours out subsidies, and we see that when faced with the elements that I've just described, subsidies can help catch up a part of the economic disparities, but all the rest is lacking. So obviously it's important to work and have a better connection between universal health care, which is CMU in France, and the other social systems. But we also have to work on the rest. We have to work on the offer, and not just a silo-based system, but have a better coordination of healthcare. We also have to work on the territorial rationale. We have to work on technologies, because there are certain areas where technology can be positive, especially in these medical deserts that we call them in France. And we also have to work on education. In France, when you see we have 161,000 young people who leave school without knowing how to read, write, or count every year, although we invest 6.1% of the GDP, this is terrible. When you don't know how to read, write, or count, the access to the healthcare system, just like access to anything else in our complex society, will be very difficult for these young people. So this is what we need to understand. If you want to fight social inequalities with respect to healthcare, it is possible, and it's possible even in an economic crisis, and it's possible even if the budget doesn't increase. But we must accept to have policies that are coherent. At the very basis of the problem, and this is the end of our roundtable, I think, but today we're in a system where we have to stop curing disease and start curing the patients. you've said one of the great problems of the problem in France is being too focused on the hospital. And yes, being hospital-centric is part of the problem. The absence of complete coordination with private medicine when people go home, etc. There is too much of a functioning in silos. And we also have this policy which is completely segmented. And we don't have any overall holistic approach to this problem of healthcare inequality. The countries that have made progress have had this holistic global approach. When Nicolas Bavrez says you can fight with subsidies and it doesn't work, in certain cases it doesn't work. You're right. But let me take the example, the most spectacular example that I have is housing aids that have gone from 0 billion to about 30 billion in housing allowances and that have not decreased the percentage of financial burden on the modest households for housing. When you compare the inflation of rents and the inflation where there's no housing subsidies, 90% of these amounts have just been absorbed with this inflation differential. The fact that the rents have increased. So these 30 billion euros have just been, have evaporated due to inflation. So we need to fight these systems. This is why there's a very complex debate. Should we block the rent or should we not? Because after 30 years of being encouraging these housing allowances, you see that we haven't found a good solution. There are about 10 of these topics in our French system today that need to be addressed, where we're spending money and to compensate for a mechanism that we have no control over. It's as though we did symptomatic medicine and not causal medicine. The second thing is, if we want to act on the determining factors, we have to act on a certain number of fundamentals. For example, school cafeteria prices. There is a whole portion of the population that doesn't use the school cafeteria and eats junk food. There's been a lot of work done in cafeterias to ban sodas and introduce more fruit and vegetables. And why not have a free price for some people rather than a tariff according to their income? So here again, there are a lot of topics that I think we can act upon to reintroduce the underprivileged back into a more all-inclusive system so that they could benefit from the global progress, which is only benefiting the more wealthy populations today. Now, yesterday I heard you talk about drugs, and they said that the response was it was the hospital's fault, and I would love to debate with you on the hospital. But this being hospital-centric is not a good system if indeed the hospital... Let me give you one example. It's not good to be hospital-centric if we take, for example, let's take something where there's a gradient between poverty and rich people, which is obesity. If in the hospital they organize bariatric surgery, plus 15% of increasing surgery for obesity, I propose that we spend some money to equip trucks so that they're specific emergency trucks for obese people. We're spending a lot of money actually to enlarge the maternity ward rooms and beds so that fat women can have their babies more easily. So there's actually a market here for obesity. And that, to me, is close-minded, hospital-centric reasoning. So, and otherwise, and I think we really need to help these women understand their errors rather than just enlarge the emergency vehicles and the wards. So if the hospital could get organized to partner with prevention policies, yes, in that case, the hospital would be doing something else more preventive than what it's doing today, and it would have its role in the system. Maybe that's what we're saying, yes. It would be a different hospital that would participate in an organized system, and I believe that the hospital and the major university hospitals have a role to play in the organization of the system and not just as a centrifugal funnel. Well, I'd like to add one thing on hospitals. I'd like to say that we talked a lot about inequality of access to healthcare. I'd like to point out that access to healthcare explains about 10 to 15% of inequalities. So it's other inequalities are much more important than access to healthcare. If we look at school cafeteria prices, yes, that is very important because we forgot to talk about one very important aspect, which is children's living conditions and everything that happens later on. We know that the parent's profession has an impact on adult mortality of the child, independently of this child's social class when they're young or when they're older. So if we really want to do something, we know that we need to focus it on the childhood phase. For example, school cafeteria prices, yes. We need policies that encourage children from early childhood. And all three of you, I'd like to ask you something. And I'm at the start of the century, we used to say these bosses used to be caricatured with they were fat and they had big cigars. Now we see that bosses are thin, they do their jogging, and they no longer smoke. And yet the health problems aren't changing. There's a real reversal of the economic gradient. Why doesn't this play a role of an example? That's what I'm working on. It's very interesting. There's a sort of, I don't know if you know the theory of innovation. It's a theory that says that the elite always follow the most healthy trends and have the most innovative technologies. And so whatever the factor that determines health at a given moment, the elite will always be accessing these trends. But gender equality, we see in terms of life expectancy, is actually, this difference is decreasing because women are smoking more. Yes. So these inequalities will continue to maintain themselves. Well, we have to be very careful. There are inequalities that remain. Let me remind you that in the 19th century, life expectancy of a minor was 45 years. And today, life expectancy in good health has really progressed. And people used to die in the workplace. A whole part of the population used to die at work. So we cannot say that the system has remained stable and that we have a structural inequality rate when we have a capitalistic system. That's Piketty who claims that the same thing. When you look at the statistics, he takes the profitability rate of capital, looking at risk, and he's not including tax on capital. So in reality, luckily, when you look at it, we don't have the same profitability of capital today as in the 19th century. So we shouldn't forget that welfare states, yes, are suffering. Yes, there are problems to address. Yes, they're less efficient, but we have societies that are much more complex. But they have allowed, the welfare state has allowed fabulous progress. Let me recall, especially with the elderly, we went even too far, but we eradicated the poverty of the elderly, whereas in the past, this was where there were huge problems. So we cannot say today that the world has been stable. Today, we can say, however, that in complex societies, yes, the inequalities are also much more complex, because what is true about health is also true for education and the barrier of mobility in our society. But we cannot say at all that we are in societies of the 19th century. And this is important to highlight because we would be mistaken when we're looking for the answers. In systems where there's limited public money, we shouldn't be making any mistakes. And even if it's unpopular, I believe that we need to target public money on the people who really need it. And I have no hesitation here. I think it's extremely important to do so, and that this will be my concluding remark. When we come back to the motto of our republic that was chosen, freedom, equality, fraternity, liberty, equality, fraternity, what is behind that? The idea that you need to put people in a situation where they're not passively subjected to their destiny and they can act. Obviously, a lot of things happen, And health is decisive here. And what we've missed the boat today, and what we need to go back to is we need to place citizens in a position of, obviously there will never be zero risk for health, just like anything else, but put citizens in a position where they will not be passively subjected to healthcare hazards and be in a position where they can manage the risk. A certain part of the population will be able to do this increasingly with certain technologies, and so we don't want the other portion of the population to be ignored and not be able to do so. All of our fellow citizens should be in a position to be able to manage their health, and indeed with...
I agree, and I'm going to come back to a specific point. We're talking about life expectancy. What about life expectancy and good health? The HAL of the WHO, for example, it's health-adjusted life expectancy, so the life expectancy planned. So it's almost the same at 65 between men and women. But for workers, they don't live as old and they don't have as much capacity. And this brings us to the problem, the ability of people, and how do we cover and manage dependency. It's going to be a problem of money. It's going to have an impact on power and knowledge. Yes. What's the pay, the PHP? What is your position on those? And that's why today we need to change things. We need to maintain people, maintain their autonomy. We need to look at life paths. We need to look at the experiments in Florida. We're a generation behind in France, apparently. So if we're in a system that's completely disorganized, that seems obvious to me. I just wanted to add something, because we all agree that there are differences in life expectancy between rich and poor, and that comes from behavior and upstream of the health system, not in the health system itself, but the health system must not worsen these differences. We've had some examples. We had some examples yesterday in the round discussion. It's easier, for example, if my sister-in-law can see a certain nephrologist that I happen to know, there's inequality of education, inequality of information, inequality of orientation, inequality of management, inequality of health coverage. So there are big, big differences. Now, the specific aspect of France in relation to other countries is to have tried to build a system and to try and improve that system today, a system in which there is no social segmentation. In other words, the establishments that might be considered as the best in France or wherever are establishments where you can have access if you're a VIP, but also if you're a very poor person. And that's the key to the system. If we had systems that were specialized, so systems for poor people, systems for rich people, well, they would consume money without having effect. We wouldn't attract good doctors. So we need to maintain a system that covers everybody, VIPs and very poor people. And for this, we need to be very careful in terms of information modes, access methods. We must make sure that we're not in a circuit that is closed. We don't want differentiated access in terms of waiting times, etc. You won't prevent that. You won't prevent that. But it's a question of organization. You know, it's about the times. Sylvain, you would like to react, maybe? Yeah, I just want to remind you that we can think of policies that focus on equalities. In all government policies, we think about equity in all policies. We've got this reflex. We think about the impact that a certain policy might have on health inequalities. Well, thank you very much. I just want to conclude by saying that for the foreigners who are here, and there's a paper published in the Lancet in 2008 that talked about the GDP and health expenditures and how that ties in to better health at the age of 50. Now, France has its system. Then there is Korea that has a very good system. And with these criteria, France is in the middle of the world, whereas Denmark, 68 years for men, 70 for women. Denmark, it's 73 and 74 with a lot less money. So we still have a lot of money a lot of progress to make in terms of life expectancy in general. Thank you.